IC about various aspects of medico-legal intricacies for the practicing ophthalmologist. I will be starting with my introduction.
I think hello, good morning all. Is this mic on? Yes, sir. Yeah, hello, good morning all. I think Dr. Viral Shah has designed this IC in a very nice way. Since years together, he has been presenting his IC on medical legal aspects in All India Ophthalmological Society, Maharashtra Ophthalmological Society, Vidarbha Ophthalmological Society, and many more occasions. So I take this opportunity to invite Dr. Viral Shah. The topic is Introduction to the IC, Unravelling the Medico-Legal Intricacies for the Practicing Ophthalmologist. Dr. Viral, please.
Thank you so much, Marathe sir. So, I am Dr. Viral Shah from Shah Hospital, Nagpur. So, as we all know, these are very turbulent times for our ophthalmic practice. Day in and day out, we get such headlines screaming in the newspaper. Eye center paid to pay 5 lakhs compensation, doctor sued for 19 lakhs, eye surgeons sued for 1.78 lakhs and all that. So, these are now our almost once a week or twice a week, you will see such headlines in national dailies. So, keeping this in mind, we have designed this course outline. I will be speaking, Dr. Marathe sir, we have got Dr. Marathe sir with us. He will be speaking on Consumer Protection Act 2019, what's new. And I will be speaking about the correct way and method of obtaining informed consents. Professor Dr. Rajesh Joshi sir is with us. He will be stressing on the correct foolproof method of documenting and recording and storing clinical case details. Dr. A. Deshpande sir was supposed to be our co-instructor, but because of his family emergency, he has left yesterday. So I think Dr. Prakash Marathe sir will be covering for him, and he will be speaking on if you receive a patient has sent you a legal notice, what should be your next step. Dr. Raju Mundra sir we have got from Aurangabad. He will be speaking on some important landmark court judgments related to ophthalmology and lessons to be learned. Dr. Vardhan Kankaria is already chairing a session in the next hall. He will be joining us in half an hour. So he will be speaking on professional indemnity insurance for ophthalmologists, fine print decoded. So I think it's a well tailor-made course, balanced course for all the ophthalmologists. And so I request first of all our senior most ophthalmologist and past president of MOS, Dr. Prakash Marathe sir, to please guide us about Consumer Protection Act 2019. Sir.
Good morning, everyone. I think this is the wonderful IC designed by our chief instructor, Dr. Viral Shah. Unfortunately, most of the delegates, they have left, and those who are there, probably one of the response I heard from my colleague, they are frightened. They are afraid of these medical legal aspects. Why to go in deep? Why to read? Why to study? Why to learn more? But then that is not the correct aspect. You must know about the problems in medical legal aspects, because someone may face that particular trouble any point of time. You never know what's going to happen. The topic allotted to me is Consumer Protection Act 2019. What's new for the practicing ophthalmologist? Dear colleagues, this unfortunate Consumer Protection Act started in my own city of Pune in Maharashtra in 1986 by Grahak Panchayat. Those days, they tried even medical profession under that Consumer Protection Act. And then after 10 years, it was finalized for medical fraternity. After that, it was revised into 2019. And the rumor was there amongst medical fraternity that we are happy that we are not under the purview of Consumer Protection Act 2019. But dear friends, that is not correct. Because there is an exclusion list by the court. And in that exclusion list, doctors and medical fraternity are not written. Unless it is written in the exclusion list, we are under purview of CPA 2019. Remember this. So remove this confusion from your mind. And what new things are added there? What are the real changes in 2019? Whether they are favorable for us or against us. This slide is very important. There are few things added. The first important thing, what I said just now, that medical fraternity, whether it's there or not, at present, till this point of time, yes, we are under CPA 2019. Next important thing is compensation amount is increased. Like what it was there in lakhs in the past has gone to crores. But little bit better thing for us, it is related to bills. What bills we are charging as ophthalmologists, and not only ophthalmologists, but for other fraternities of medicine, the bill most of the times doesn't go beyond 50 lakhs. So, if it is related to the bills, probably much more compensation shouldn't be asked for. That is the thing. Next important thing, which is worst from our point of view, is jurisdiction anywhere in India. Suppose you are practicing in the city of Mumbai and the patient coming to you having his address or her address in Haryana. And the complaint in the past was supposed to be lodged in Mumbai only, Maharashtra only. Nowadays, the place where the patient and relatives they reside, they can lodge the complaint in their own city, in their own state. That is the worst thing. Next addition thing is, it can be online application. Very easily available and accessible from everybody's point of view. So danger is, it is easily accessible for patients and relatives, so they can be tempted to make complaints against medical fraternity. Next important thing is, whenever the case is going on in consumer forum, there is provision of consumer mediation cells. This particular provision is not good, not bad that way. Sometimes the out-of-court settlement has been promoted by these bodies, that is mediation cells. And even if you haven't done anything wrong, you are tempted, you are asked to do the settlement. And that way these mediation cells are working. They are blackmailing the medical fraternity also for out-of-court settlement. Even the indemnity insurance companies are saying, why to go ahead? Even if you are not wrong, they are asking you, promoting you, motivating you to do out-of-court settlements, and that is about mediation cells. Doctor-patient relationship, what we have been talking about since years together. In the past, it was really good because medical fraternity was treated as profession. And after this Consumer Protection Act, it comes under business. So doctors are treated as sellers. About patients, they were clients in the past because we were professionals. We were treated as professionals. Nowadays, because the definition has changed, they are now consumers, they are buyers. And what has happened because of that? They are thinking, government and all, that it is pro-patient. So patients and society will be benefited at last. That's what they thought in their minds. But no, it is anti-doctor. And that is the worst thing for medical profession and doctors. But what has happened because of that? Even patients are receiving bad taste of it. Because what was there in the past, 25 years ago, 35 years ago, doctors, they were taking the risk, they were taking the chances of treating even the serious patients. And most of the times, the results were good. But even if the result is bad, they were not blamed because they had that confidence about patients and relatives and society. But nowadays, nobody is trying to take those chances or that patient who is having complications. That risk they are keeping in mind, and maybe some sort of defensive practice which is called. For medical legal protection, what medical fraternity has been doing just to protect themselves, some investigations are being done, CT, MRI. Probably because in the court of law it is asked, what precaution have you taken? Have you investigated the patient properly before telling this particular line of treatment? Second opinion is asked for because sometimes you may feel, why to take the chance? Send the patient to another hospital, secondary or tertiary, ask them to have their second opinion. And what I said is the defensive practice. Like in the past, they used to dare to treat the patients. And nowadays, what you say, you are sending the patient to a higher center. Why to take the chance? Why to take the risk? Like in ophthalmology, suppose the accident patient comes, corneal suturing, perforating injuries, no chance. Suspicion of endophthalmitis, panophthalmitis, no chance. Send the patient to government hospital or health center. So this is defensive practice. So it was faith in the past towards medical profession. What's that? Today and tomorrow, it is a suspicion. Medical fraternity is looked at with suspicion by the community, by the general people. And that is the worst thing. And hence, both are affected. Doctors' medical fraternity as well as patients and general community. Doctors are answerable surely to so many things like medical council, it is state medical council and national medical commission nowadays, civil courts, criminal courts. Just now we are talking about this consumer redressal, Janata Darbar, all simultaneously or sequentially. So CPA is a special law of civil nature with the aim of social welfare to protect consumers with the following features. No court fee. So now it's up to 5,000. Simple procedure of filing, hearing, decoding, etc. Summary trial is there. Speedy redressal. Then non-judicial members on the forum. One has to be the female. Not a court, but has a full force of it, that is QC judicial. Majority opinion is the order of the forum. Act is compensatory and not preventive or punitive. Then applies to all paid goods and services, but only free services covered are medical. Should I continue or stop here?
You can continue, sir. We can cover.
So jurisdiction, you know, district forum, state commission and national. So for district, it was less than 20 lakhs. Now it is 1 crore. For state commission, it was up to 1 crore. Now it has gone to 10 crores. About national, it has gone from 1 crore to more than 10 crores. And in the procedure, so summary procedure, complainant in 4 to 6 copies, complaint has to be there in 4 to 6 copies, affidavit has to be made, prefer to, and the thing is refer to the opposite party, reply in 30 days, that can be extended up to 15 days more. Hearing by president and at least one member in the forum. Lawyer is not mandatory. Evidence of affidavit, expert, book references and everything. Order to be signed by president and one more member. An ex-party decision can be given. So appeal system, everybody knows, district, state, national commission and Supreme Court. So these are the some proposed changes we already talked about. Thank you so much all of you for the pleasant, happy and safe practice.
Thank you so much, Marathe sir. That was really needed because there was a lot of confusion between this new Consumer Protection Act 2091 that the government has passed, and much confusion was there whether the doctors are under its purview or not. But recently also the High Court has given a decision, Delhi Court, that doctors are liable in this CPA 2019. So yes, we all doctors and ophthalmologists are liable under this CPA 2019, and we should tailor our practice keeping this in mind. So the next, I think.
Now I invite Dr. Viral Shah, who is the chief instructor, and the topic is related to consents. Consents are very important. So the correct process and method of obtaining informed consents before ophthalmic procedures. Before Dr. Viral Shah starts, I should tell you that at All India Ophthalmological level, there is one booklet which has come that is about informed consents. And those informed consents were in the language English. And basically, the consent must be in the local language. So we have translated the whole booklet. Our team, Dr. Rajesh was part of it, I was the chief coordinator. And we have come out with that particular consent booklet. It's easily available on MOS website. You can download that particular procedure related consent. And the same has been transferred by another language people in another few states of India. And that process is still continued. Over to you, Dr. Viral.
Thank you, sir. So the correct process and method of obtaining informed consents before ophthalmic procedure. So we all know there are printed forms, ready-made forms, but what is the correct process? How to go about it, how to convince the patients and relative, how to counsel? I would like to stress a little bit about that. So informed consents, the law as it stands today, essential guidelines, understanding the problem, why informed consent is needed, why patients decide to sue or file complaints, relevance of a consent form, conveying caring attitudes with information, the process of informed consents, and integrating the process and the form, and of course various model consent forms. So informed consent, the law as it stands today, as a starting point, it is necessary for all of us to understand some of the basic legal fundamentals behind consent law. What is the definition of informed consent? Informed consent is defined as a process for getting permission towards medical treatment by a patient granted in full knowledge of the possible consequences, risks, and benefits. Most Western countries have already shifted towards patient viewpoint standard. That is, the information disclosed should be based on what a reasonable person in patient's position would want to know in similar circumstances, whereas in our India it is a reasonable physician standard which defines disclosure based on what a reasonable doctor should disclose in the medical community, should customarily disclose to the patients under same or similar circumstances. The law clearly states that ophthalmologists or doctors have a non-deligible duty to disclose and discuss with patient. Non-deligible is you cannot give it to your subordinates or anyone. It is your duty to take the consent, at least inform the patients about that consent. And the point that should be covered are the diagnosis, the nature and purpose of the proposed treatment or procedure, risk and benefit of the proposed treatment, alternative methods available, and the risk and benefits of such alternatives, and risk and benefits of no treatment. So why this informed consent? What is the problem? Why these informed consents have cropped up? So almost 95% of ophthalmic negligence court cases decided during the last 5 years were terminated in favor of the ophthalmologist. So ophthalmologist won all the cases, 95% of the cases. The question arises, why these cases were then filed when there was no chance of the patients getting any relief from the court? The simple answer to that was the patients sue regardless of negligence because they are surprised by the clinical outcome, or they are angry with the provider or the ophthalmologist who they strongly believe to have caused this grief. General assumption that most patients are motivated by personal greed or predatory lawyers are unproved and not usually the fact. All data in literature suggests that most patients or their family members who file family court cases and claims regarding medical negligence strongly believe ophthalmologists did not warn them of the potential medical problems and doctors tried to mislead them. In such a scenario, when such emotional factors are involved, even the best constructed legal forms, consent forms, becomes virtually powerless to forestall litigation. You have to face the litigation. You may have taken the consent and that you can provide as a evidence in the court, but litigation you cannot avoid if you have just signed the form and not gone through the informed consent process and given counseling to the patient. Consent form coupled with patient's perception that important clinical information was personally conveyed by a caring physician could help prevent many unexpected medical notices. A physician who expressly, you have to convey caring attitudes with information. You have to show to the patient and their relatives that you are caring for them. So you have to have certain, express certain clinical uncertainty if there, empathize with the patient's wish for positive outcome. Consent activities, the process for informed consent. The process starts when the patient first encounters the doctor and continues through the operative and post-operative treatment phase of the care. Forms and signatures are merely an end stage culmination of the process and it is not the focus of the process. Informed consent is still regarded in many ophthalmic practice as a discrete legal event rather than an interactive process. It is important to change this mindset of ours in the entire and the entire patient care team has to be sensitized regarding at the same time to alter this procedure. Hospital support staff, they are very important. Nurses, paramedical personnel and administrative assistants, they must be encouraged to shift their focus from paperwork of consent to the ongoing process that is continuously happening. Documentation is important but should not be the sole objective. When possible, start the consent process as early in the continuum of care as possible. This doesn't mean immediate recitation of risk benefit, अरे ऐसा करेंगे तो ऐसा हो जाएगा, ऐसा नहीं. But you sensitize कि ये आपको ऐसा ऐसा बीमारी है, ये possible solutions है, आपको ये करना चाहिए. So you start sensitizing the patient about treatments and alternative, and interactive exchange of relevant information should be done. A large number of patients and their family perceived that doctors would not talk or answer questions, and many believed no one in the hospital was listening to them. Try to make arrangements to have family members present and included when discussing patient disease and the planned medical treatment or surgery. During the initial or subsequent visit, introduce the consent form and explain its purpose. Clarify that the patient form is intended to help both the doctor as well as the patient. The important facts which matter to the patient have been discussed and are understood, and be very frank and honest in your clinical uncertainties. Give the patient a copy of the form for or documentation either before or after it is signed. This is important since some studies suggest that patients believe doctors cover up or downplay important information. Fear about giving patients a copy of the consent form is usually worse than it is a reality. If patient appears troubled over the risk and uncertainties, you again counsel them and empathize with their wish for a good result, accept their ultimate decision even if it doesn't agree with your clinical opinion. This is their right under the law, and if the informed consent process was properly handled as described earlier, there should be no animosity. When possible, make contemporaneous note in the patient's record during all phases of consent process, even if a form is used. Nowadays, they are also saying that you have to video record the process of consents, important consent, but it is not law. It's law only during transplant procedures, even only during transplant of vital organs, not even corneal transplants. So kidney transplant patient, video consent is a must, but in ophthalmology they have not yet made it a law. When possible, make contemporaneous notes in the patient's record during all phases of the consent process, even if form is used. The best way to document such information, and more importantly to record that a consent process took place, is still through the use of pre-established forms. So nowadays AIOS, MOS and all bodies have come up with beautiful and comprehensive forms. You can download it online also, or it is available readily with their office, or you can contact any of our instructors. They will provide you the link or pro forma of how the consent for various diseases can be taken. It is essential for each members of practice management team to regard such documentation not as just another document to complete, but as an important informational tool to establish a strong relationship with the patient and ophthalmologist. Short form entries should be avoided until handwritten entries can be improved to the level where their evidentiary value consistently exceeds that of properly developed pre-established form. The printed forms are the way to go. The use of consent form for most operative procedure is still the best way for ophthalmologists to document the whole process. There is no one right or wrong answer in designing an ophthalmic consent form. Like all parts of the medical records, the consent form must represent that the ophthalmologist made a reasonable effort to effectively carry out this important duty as part of patient's ongoing care. A number of ophthalmic specific forms are already available on various websites. You can visit any of these: DOS online, AIOS online, MOS online, or you can contact us. Thank you, that's all.
Thank you, Dr. Viral, for wonderfully covering the topic. I think it's the need, your documentation must be perfect.
I just wanted to know whether the consent form that we are making patient to sign, has it to be in the mother tongue, or it will be Hindi or English?
Even if it is in Hindi or English or not in a mother tongue, you have to mention that he has been explained everything in the mother tongue of the patient.
If we just write down in our own handwriting, is it?
Because he is a Punjabi or a Bengali patient, you may not be having that form with
Yes.
Maharashtra. So you have to mention that you have the patient and relatives understand, you have explained the whole process in their language that they know.
Okay.
But they can sign it and they can write a line that I have been explained in my mother tongue the whole process.
The patient has to write on
Patient has to write, and you have to take a signature of witness of their relative.
Some relative of the...
Sir. This is the basic. If there is no consent form, your case doesn't stand. This is the first evidence they will ask whether consent was taken or not. In evidence, this is the first document they will ask.
Something bad happens to the patient by chance, and suppose his consent is not taken, everything goes against you. Suppose you have taken consent, at least you were in a position. The cases have happened. One of the colleagues who was general surgeon just took out the cyst and the patient was dead on table. The consent was not taken. Afterwards, he tried to take the thumb impression of the patient, and the patient was literate. So thumb cannot be correlated. So not to have consent is a very bad thing.
Consent is a must before any incision or any procedure in the body, unless otherwise it amounts to assault.
Sometimes the blood relative is not present. So if the attendant signs,
Yeah, attendant or friends or someone, but you should mention their name and mobile number there. You should get there.
Basically, you can have two witnesses. Most of the times, if you take the witness that is a relative of the patient who can go against you, and you can have another witness who is not in relation to the patient but some other patient's relative. So both those witnesses will be working, one in patient's favor, one in your favor, and that way you can do it.
So, but according to the AIOS consent form, there are two parts to it. First is the information, below which also there is a sign that we have explained this, and the second part of the consent is on the day of surgery when they are going to go for the surgery.
Yes, that is the process of consent. That is the whole process. Even if in the OPD also you need to take consent for some procedures
so
like
that
FFA and all
As an
that.
independent witness, then you cannot take your staff signature.
Just now I can say about that. Sometimes patients and relatives, they say that the consent was taken so early. Other objection is consent was taken so late, that is on the day of surgery. So there is a choice that when the patient is coming and finalizing the surgery, you can give the consent form to the patient, ask him to read at home, get that signed with him, and again on the day of surgery you can have another consent form. So that way you have told the patient beforehand, that is quite early, and then on the day of surgery, that is not that.
So, like how I follow is I have two forms. One I give, it is attached in the file only on the day they come for the A scan. We take the consent, explaining the fact that we have explained you the surgery, and on the day of surgery, the second part of it, which is there, which is for the surgery.
Yes.
That's good.
So that is the
That is the
time
correct-
No,
that
but
is the
I'm
correct
asking
way.
you as a second witness when you said, is
They
your
can be-
staff, is your staff member eligible
Yeah.
to be a second
Yes.
witness?
Yes. Suppose nobody is available, if you can definitely do that.
Yeah, one more thing I will add to this discussion. Nowadays, most of the practitioners, they email or WhatsApp consent form so that patient goes through everything, and whenever he comes for the surgical procedure, whatever, like scan, what you told, then he can sign the consent form because he understood the whole process. That we can assume. And apart from that, there won't be any queries. If at all, if he has got some queries, he can answer. He can ask that time, and we can answer properly.
But the weightage is given to the form that is signed on the day of the
Yeah.
surgery. The weightage will carry, because if the first form is not there and second form is there, that's it. But if the first form he has signed after 7 days, 8 days when he has come for a scan, and on the day of surgery you have not taken consent, it won't carry any weightage. So
Yeah.
now, we have got with us Professor Dr. Rajesh Joshi sir from Nagpur. He is Honorary Secretary of Maharashtra Ophthalmic Society also, and he is having his practice at Nagpur Orivision Eye Hospital. He will be stressing on the foolproof method for documenting, recording and storing clinical cases details for ophthalmologist. Sir.
Yeah, thank you and good morning to everyone. I thank Dr. Viral for inviting me for this or including me in this IC. If you don't want any worries to be invited after any procedure, you need to have a foolproof record of whatever you have done, like you have examined in the OPD or you are performing procedure. So I will be dealing with how to maintain the record on case-based scenarios, and what is the importance of record keeping apart from whatever I have elaborated, like evaluation of own results and all. The most important part of record keeping, it's helpful in medical litigation. If you are working in a corporate hospital or government hospital, there are medical record section in those hospitals. So you not worry about those things because they keep all the records and you can go and find out the record. But if you are a solo practitioner, you must have a copy of whatever you have done. So for that, record keeping is most important. The legal system relies mainly on documentary evidence in situation of alleged medical negligence. And poor record means poor defense, and no records means no defense. There are various ways to keep the record. The manual method. A large area, it occupies large area and difficult in retrieval records. If you go to this room and find out a record of 10 years back, you won't be able to find out or retrieve the record. That's why electronic record system has come into existence, and it is most preferred way to find out your record just on a click button away. Data can be easily retrieved. Prescription is fully typed, so you can you don't have to see what you have written 10 years back, because handwriting might change. Previous data of patients is easily available. Fundus photos, OCT perimeter images are easily available on one click. Now, medical records. What are the medical records which you are supposed to keep, and what is its importance? How documentation of medical history is important. A fellow underwent cataract surgery which was uneventful, but there was no improvement in the visual acuity. Patient approached consumer forum, result in favor of doctor, because in history note it was clearly mentioned decreased vision in the eye since childhood, as patient had amblyopia. So doctor escaped from getting sued. Now, clinical findings. Why clinical findings are important? Cataract surgery which went uneventful, recurrent post-op inflammation and iritis with all possible treatment. I ultimately went into phthisis. Patient approached consumer forum, and result was in favor of surgeon. Because pre-op documentation clearly mentioned that patient had a complicated cataract, and all signs of healed uveitis were there, and cataract was operated under the steroid of cover, and the eye was absolutely quiet before 3 months. So this is how clinical findings saves your day. Investigation and documentation is also very important. Cataract surgery in diabetic eye, approached consumer forum for non-improvement of the vision. Results still in favor of doctor, because pre-op OCT findings had showed that patient had pre-op macular edema which was treated by vitreoretinal surgeon, and patient had received anti-VEGF also before cataract surgery. So this classical case of documenting evidence of investigation before cataract surgery saves the day for the surgeon. Pre-operative care and documentation. Cataract surgery which was uneventful, patient developed post-op endophthalmitis, intravitreal antibiotics were given, patient was referred to vitreoretinal surgeon, vitrectomy was performed, all care was taken by vitreoretinal surgeon, proper referral was there, case filed in consumer forum for compensation for non-improvement of vision and all mental and physical trauma which patient had to undergo after cataract surgery. Surgeon still escaped because pre-op notes mentioned that fumigation and autoclaving was properly done. So whenever you perform fumigation or autoclaving, there are strips which you can stick to your records. Betadine eye drops were put and mentioned on the case paper. Pre-op antibiotic drops were instilled, which was also mentioned, and patient was referred to vitreoretinal surgeon for further care. You are not supposed to know each and everything. So if you find that it's difficult to do at your side, you can always refer to your colleague. Operative note documentation, cataract surgery, patient had a compromised vision, patient still filed a case, result in favor of surgeon because operative notes documented that the patient had posterior polar cataract, and as you know that posterior capsular dehiscence may occur anytime during the procedure. And notes also mentioned that patient had a vitrectomy on the table. So detailed OT notes, they are absolutely important. So once you finish off the OT, and if you find that there are some problems during the procedure, you can always mention them on the OT notes. Opd prescription is also very important. You have to write down full name of the patient, date, treatment preferable in capital, duration of the eye drops which were mentioned, signature of at the end of the document, and review date. Date is very important because undated prescription can lead to doctor in a trouble if patient misuses the prescription later on. Case of giant papillary conjunctivitis, patient came to ophthalmologist. Patient had prescribed some drops which were for particular days only, but patient used those drops for long period. Patient developed glaucoma later on, but the surgeon has mentioned that you have to instill these drops for 10 days, 15 days, and it's not for long term. You can explain to the patient these are drops for 5-10 days only, but usually whatever you say, the patient forgets. And he keeps using those drops for redness and whatever. So that's why, that is how the ophthalmologist escaped from the case. OPD prescription. Now discharge summary, another very important document. You have to write down date of admission, date of discharge, date of surgery, surgical procedure, treatment advice, precautions to be taken post-operatively, and date of next follow-up. Whatever you tell to the patient post-operatively, your attendant, yourself, patient usually forgets all these things and keeps on doing whatever they want. Discharge summaries should be signed by consultant. Copy should be kept with surgeon. Discrepancies in discharge summary and hospital records can raise suspicion about tampering of the record. This should be avoided. Referral letter is another very important document, and it should include date, issue of the certificate, patient's condition, cause of referral. Duplicate copy of the whatever you have given to the patient should be kept with you. Maintain the register of medical certificates. Often on we get patients for the certificates like leave for so many days and for so many disease, whatever patient had. So these documents are very important. They can be misused by them later on also. So identification mark and patient signature is also important. A lot of cases of patient misusing medical certificate has been seen due to lack of date, time, and issue, which is issue of certificates on backdated. MCI guidelines for record, they are not clearly mentioned, but for consumer forum, patient can approach as outdoor case within 2 years and indoor case within 3 years. I just heard some eminent personality lecture day before yesterday only. He told that the OPD paper you should keep with you for 3 years and indoor for 5 years. And you, if at all in need, you should keep a copy of it in your record, maybe scanned copy or recorded copy with you for as many years as you want. If patient demands, case paper should be given within 72 hours. In pediatric cases, until the patient attends measure, you should keep the copy of the record. In medical legal cases, doctor should preserve until the case is resolved. So medical record is an important aspect of one's medical practice. It not only helps you to improve your patient management, develop your treatment plan, improve personality and presentation in publishing studies also, but also helpful in legal problem whenever it arises. So I think that is the most important thing which you should keep with you. And thanks for your patience listening. Thanks Dr. Viral for the opportunity.
Thank you so much, Raju Joshi sir, for finishing the talk exactly in time. So that was very insightful talk regarding documentation, recording and storing clinical data for all our ophthalmologists. So if any questions are there, so we can take it at the end also. So our next speaker was supposed to be Dr. Deshpande sir from Aurangabad, but because of family emergency he has left yesterday to Aurangabad. So in his place Dr. Prakash Marathe sir has been kind enough to cover. So he will be speaking on patient has sent a legal notice. What should be your next step? So this is a nightmare for any ophthalmologist. You are busy in your OPD and suddenly a paper lands on an envelope lands on your table and you open it and it's a legal notice from a lawyer or a patient, and suddenly your whole mood gets off. You don't know what is happening in the OPD, what is your OT list, and you lose the taste of your mouth also. But we have got remedies for that, and Dr. Marathe sir will be covering it.
think the topic allotted to Dr. Deshpande sir is very, very important. So you have taken consent, you have written notes, you have done the procedure, everything has gone all right or might not have gone all right. What next? The patient has sent a legal notice. What should be your next step? There are few versions, notice is there, throw it in the dustbin. Somebody says that take it seriously, go to the lawyer. Somebody says that this is to be done, this is not to be done. There are various types of notices. The notice may come from the patient, maybe from relative, maybe from lawyer, maybe from government, and so many things. So the way you have to react is very important. So this is presentation by Dr. A. Deshpande, who is chairman of Legal Cell All India Ophthalmological Society and Maharashtra Ophthalmological Society. On his behalf, I am presenting this. So patient himself or through advocate, this is very important. Patient, suppose the sending notice to you, or advocate is sending the notice to you. Dr. Viral, please. Dr. Viral, please. And the notice is there, and some patients and hospitals, they say, we didn't get the notice. Somebody in the hospital has taken that, not given to the doctor. Still you have received the notice because somebody on your behalf is signed that it is received by you. Means you have not taken proper care and received that particular notice. The notice can be from civil court, consumer court. My previous talk was about consumer court. Then MCI, that is Medical Council of India, now it is National Medical Commission or State Medical Council like Maharashtra Medical Council, etc. It can be from police station, it can be summoned. Then criminal court called as warrant, it's very serious. That time you should be careful. For other agencies as health agencies, corporation, etc., that can be about other things, biomedical waste and hospital registration and fire NOC. Ophthalmologist should take care of few more things, few more steps. He will not refuse the notice, as even if you refuse, it will be taken as granted. So take it. It is not mandatory to answer the notice of a patient and advocate. The notice has come. There are two options. You can answer the notice. Other thing is you may not. You may answer at the next step if you feel like. Because if you have answered, that particular version is again taken as proof. So you should be mentally prepared what answer you are supposed to give. Other notices answer with the help of advocate. Now in this case, three people can answer, means doctor or hospital. Second is advocate, and third is medico-legal expert. So medico-legal expert is the doctor who has got additional knowledge. Doctor-advocate is the best combination. That is, you must consult medico-legal consultant rather than advocate. Have an indemnity insurance. My next speaker will be talking about this. With good coverage limit and a medico-legal consultant as advisor to keep yourself cool. Then don't become panic, even if you receive a notice. This is very important. When you receive a notice from a consumer court, you have to give a written statement in the consumer court to face and defend in a better way. If it is given with the help of medico-legal consultant, it becomes more effective, just now I said, because he has additional knowledge of law as well as medical. He can represent a doctor better way than a normal advocate, and so you can win the case. See, there are some medical nomenclature, diagnosis, those terminologies. Routine advocate may not know that, but medico-legal consultant knows that. On your behalf, when the advocate stands in the court of law, may not be knowing those nomenclatures, but medico-legal consultant, definitely yes. He can help for maintaining the medico-legal records, which helps in court to win the case. For that, contact medico-legal consultant or the company. Whenever one receives a notice from advocate or court, consult medico-legal consultant or a medico-legal company and submit written statement with his help in the CPA case. You have to have your own notes, consult with medico-legal consultant, prepare the draft, check the notes properly, see that if something is to be done, that has to be done carefully. Suppose something is changed with different ink pen, then it is objectionable. The sequence of events must be perfect. The day, date, time has to be put properly. Whether proper follow-up was taken or not must be mentioned in your notes. So in criminal case, give statement to police or present in criminal court through advocate with consultation with medico-legal consultant. So complication is not negligence. This is very important. Negligence is different and complication is different. But not knowing the complication happened, not taking proper steps to rectify it, that is bad. Not referring or not taking help of proper specialist or leaving the patient on the unqualified or underqualified subordinate is negligence. You have a case. There is suppose IL drop and you haven't looked after that patient and you have told your subordinate to look after the patient like optometrist. Not a correct way. Refer the patient to VR specialist. He can take care. So proper step, referring the patient at proper time. If you are done, probably you are not in trouble. So taking proper step at proper time is must. Remember, the doctor will not be held responsible under negligence if the treatment is as per standard textbooks and or accepted professional practice and still patient suffers loss or injury. What does that mean? You have taken proper care, whatever is written in the books, and as per protocol you have treated the patient. Then it is not negligence. Or merely because a complication has occurred. So complications are known. They can occur. They are written in the textbooks. So if there is complication, does not mean that it is negligence. Only the thing is you should be able to defend in the court of law why that has happened and what proper precaution you have taken. This is about one court judgment, Supreme Court, in case of Dr. Suresh Gupta versus Government of City of Delhi. For it is held that for every mishap or death during medical treatment, the medical man cannot be proceeded against for punishment. So death does not mean, but unfortunately, this particular slide and what's happening otherwise, you know 304, 304A. So 304 non-bailable, 304A bailable. But most of the times police, they apply 304. And the worst thing which has happened in the case of Rajasthan recently, not 304A only. In addition to 304A, 304. And they have not stopped there. 302, that is worst thing, which was applied against medical profession. And she had lost her life. So these things are not followed by police and the government. So the medical man is not an insurer. He does not warrant successfulness of treatment or cure of patient. So in the past, doctor used to be arrested in table death under section 304A, but now with the decision in the case of Jacob Mathews and state of Punjab, Supreme Court has given guidelines that the doctor should not be arrested under section 304A. That's what I said. If it is 304, it is problematic for medical fraternity. It can be 304A, non-bailable, and police cannot arrest unless opinion is taken from expert doctor or the committee of doctors expert in that particular field. So role of medico-legal consultant, doctors are very poor in record keeping. We have been telling, my fellow colleague has already told you about record keeping. Advocate are poor in medico-legal knowledge. This is a little bit lacunae. So take care about and avail that thing, cash that thing. Judges, they give decisions as per the record kept in front of them. So whatever the document says, they are giving the decision according to that. Because of poor knowledge of law, doctor is not able to brief the advocate, and so he is not able to plead effectively in the court of law. So the ophthalmologist loses the case, and here medico-legal becomes the important in ophthalmic practice, dependent on him, and keep yourself cool. So about indemnity insurance policies, our next speaker, Dr. Vardhaman, will be speaking about it. At Maharashtra Ophthalmological Society level, we have started the indemnity insurance scheme, and there like group practice, there are group insurance people, they are coming together, availing less amount of premium and more coverage. The same way at Indian Medical Association level, IMA Maharashtra state has got professional protection scheme. There also this professional indemnity is taken care of. So these policies should be taken for doctors and hospital with staff separately and should be renewed every year to meet the claims of CPA. This is very important. You take the policy, you forget for 1 week, and then you renew it. See, the previous particular coverage of that particular period is on. So every year, take care that the policy is renewed before the due date. If you forget that, last 5 years, 7 years, 12 years, that is gone. So thank you so much. So even if there is a notice, don't be panic and try to respond it in a nice way. Thank you so much.
Thank you so much, Dr. Marathe sir. He is always the one we look after whenever we are in trouble. So today Dr. Deshpande sir was not there and he was very kind enough to fill his space. So our next speaker is Dr. Raju Mundra. He is practicing at Aurangabad at his own hospital, Mundra ENT and Eye Laser Center, and he is also director in Elite LASIK Laser Center at Aurangabad. He is also honorary treasurer of Maharashtra Ophthalmic Society, and he will be speaking on critical study of some important court judgments related to ophthalmology, lessons to be learned by us. Yes.
Good morning, everybody. At the outset, I would like to thank Dr. Viral for including me in this very important instruction course regarding medico-legal aspects. So I'll be talking about critical studies of very important court judgments related to ophthalmology and the lessons you can learn out of it. As already mentioned in previous talk, Honorary Supreme Court has observed that for every mishap during medical treatment, doctor cannot be proceeded for punishment. But unfortunately, these lawsuits, they are increasing against doctors mainly because consumer, that is patients, their expectations are getting higher and awareness has increased among patients, and at the same time the tolerance threshold has gone down. So it is need of our that as a doctor we should have knowledge about these legal aspects, and this knowledge we can gain by studying different important court judgments against ophthalmologists. So in this talk, we are going to discuss about different important cases, observation of courts and lessons from these observations, because you do not make all the mistakes to learn. You can learn from others' mistakes. So case number 1, patient underwent cataract surgery with IOL. Afterwards, patient complained of pain, headache and vomiting. He attended ophthalmologist and he rightly diagnosed as endophthalmitis. Immediately, patient was referred to VR surgeon where he underwent vitrectomy. But unfortunately, patient lost his eye and doctor was sued for that. National Commission observed that doctor was qualified, skilled, experienced ophthalmologist. All the tests, important investigations, fitness, all this was taken. He was rightly diagnosed and in time referred to VR surgeon for further treatment. By quoting Jaffe's cataract surgery and its complications, National Commission observed that there are several causes of post-operative endophthalmitis and doctor cannot be responsible for all these endophthalmitis. Case number 2, during cataract surgery, patient developed PC tear. Vitrectomy was done. Patient regained vision by 6/6, but eventually patient developed RD. Surgery was again done, but he developed endophthalmitis and lost his vision. Doctor was sued, but National Commission did not find doctor responsible for that. Observed that for every mishap during medical treatment, doctor cannot be proceeded against punishment, and any procedure done in good faith for benefit of patient, although it's without consent, it's not an offense, though that is causing harm to patients. So lessons we can learn from these two cases that doctor cannot be negligent if he or she is qualified, skilled and experienced, if he adopts practice pattern approved by a responsible professional body, and he cannot be negligent just because complications has occurred. Case number 3, patient was operated in free eye camp and he developed endophthalmitis and lost his eye. But National Commission observed that this being a free eye camp, it doesn't come under the CPA Act, and the case was dismissed. So all these government hospitals, healthcare center, dispensaries which are providing free surgeries, free services for all patients, whether patient is poor or rich, it doesn't come under the purview of CPA. Case number 4, patient had congenital eye disease. Doctor explained guarded visual prognosis and he was advised to get laser treatment at Eye Institute, but patient got operated for the cataract and he didn't listen, and but he didn't regain his vision, and patient filed complaint against doctor. In this case, National Commission observed that there was contributing negligence from patient because he didn't listen to doctor, and doctor was not negligent because he was rightly diagnosed and he was explained about the guarded visual prognosis. So, as already discussed by Dr. Rajesh Shah sir regarding record keeping, we should maintain all the records properly, even records including treatment refusal, investigation, surgery, everything should be maintained. Case number 5, patient post for cataract surgery. On table, patient had expulsive hemorrhage and lost his eye. But National Commission observed that as per affidavit from a very renowned VR surgeon, this expulsive hemorrhage is known complications, although it is dreaded in intraocular surgeries. So patient, doctor cannot be negligent for that. Case 6, young patients aged 14 years was advised radial keratotomy, and he was operated for same, but vision did not improve, and eventually patient developed RD and lost his vision. Litigation was filed against doctor, but in this case, as patient's age was less than 18, and literature shows that patient cannot be operated in below 18 years of age for refractive surgeries, and doctor was found negligent for the same. So this negligence is breach of duty arising due to commission of act which no prudent or reasonable doctor under similar circumstances would do. So I'll advise not to go for unindicated procedures to avoid these litigations. Case number 7, diabetic patients who had progressive diabetic retinopathy and posterior polar cataract. Poor prognosis was explained to patient. Left eye was operated for vitreous hemorrhage, right for cataract, but patient did not gain proper vision, and he was patient has filed a case against doctor. But commission observed that loss of vision was not because of surgeries but because of diabetic retinopathy. Doctor has managed the case as per standard medical practice efficiently, and doctor was not found negligent for the case. So always follow standard medical practice. Doctor cannot be answerable for any treatment which has gone untoward results. He is not an insurer, and he cannot give warranty of his treatment, and he is not responsible for all the accidents. Case number 8, known case of diabetic patient operated for cataract. Next day he had swelling and pain in operated eye, diagnosed as endophthalmitis, and patient lost his vision. But in this case, doctor did not record his basic blood sugar level, and fitness was not done, and that's why he was found negligent for not maintaining record and not doing basic fitness. So pre-operative basic tests like blood sugar level, fitness, all these should be done, and all these tests should be in permissible limits, and you should maintain that record. Case number 9, patient operated for pterygium. After 1 week, mitomycin C was prescribed to prevent recurrence, and doctor orally told patient to stop mitomycin C after 2 weeks, but it was not written on the paper, on prescription on record. Patient didn't understand this, and he continued mitomycin eye drops for more than 4 months, and eventually he developed xerophthalmia and went in court. In this case, both doctors as well as patient were found negligent. Doctor was found negligent just because he didn't give it in writing, and patient did not show up to doctor after 2 weeks. Therefore, patient was also had a contributory negligent about this case. As already told by Dr. Rajesh Shah sir, medicine should be prescribed in detail, like dosage, number of days to be used, in which eye to be used, and it should be in legible handwriting, and records should be well maintained. So take home message, do necessary investigations and keep records, explain the prognosis and take in confidence patients as well as relatives. Informed consent in mother tongue, as already told by Viral Shah sir, it's must. Treat the patient as per textbook norms, refer to patients to higher center if you feel, and be transparent and polite with patients and relatives. Before I conclude, I'd like to especially mention Dr. A. Deshpande sir, the legal consultant for AIOC, for his all help and guidance in this talk. And I'd like to appeal everybody to go through his his CME published by AIOC, that is Legal Aspects in Ophthalmology. It's available online on AIOC website. It's crisp. It's briefly. It has everything has been mentioned in this case. Thank you all. Thanks for patient listening.
Thank you so much, Dr. Raju Mundra, for such an excellent talk on this various landmark court judgments. So our next speaker is Dr. Vardhman Kankaria. He is Director of Asian Eye Hospital, Pune, a tertiary care super specialty hospital. He is a former secretary of Maharashtra Ophthalmic Society, and presently he is secretary of MOS Professional Group Indemnity Insurance Scheme. So he will be speaking on professional indemnity insurance for ophthalmologists, the fine print decoded. So as you all know, we all are having our indemnity insurance since last so many years, but we don't know what is written in that. We just know limit 10 लाख का है, 20 लाख का है, अंदर क्या है, कितने केसेस के लिए देंगे, अपने को क्या कंडीशंस फुलफिल करना है. वी डोंट नो एनीथिंग. बस वी जस्ट गिव अ चेक फॉर प्रीमियम टू आवर एजेंट and it gets renewed, or to our IMA or somebody. So we'll be delving into some fine prints and make us more aware how to go about taking indemnity insurance. Dr. Vardhman.
Thank you so much, and first of all, thank you so much, Dr. Viral, for the kind invite, and this is a much required, I think, instruction course. We all know that the patient's tolerance for the outcomes is decreasing day by day, and even for, I think, even when you have a regular cataract surgery done, and if the patient doesn't see 6x6 nowadays, there are patients who actually ask you why I don't see the last line. So you can actually understand to what extent the intolerance for very small changes is also occurring. And now here we are talking about, in the last several excellent talks, if there is a mishap, then of course the patients in today's times are not somebody who are going to leave it alone. They are probably going to pursue it legally, and that is when us as ophthalmologists should be ready in every possible way to face it, and also to continue a practice in the right possible way. So I think the last several talks have been like a preamble to what I'm going to talk to you about. I'm going to keep it very short, and especially also going to focus about what we are doing differently in Maharashtra Ophthalmological Society as well. So professional group indemnity is definitely the need of time. We all know gone are the days when the doctors were given godly treatment, and they were given a lot of respect in our society. There was a special status for being a healer, but nowadays whenever you see anybody and there is a community around you, whenever you say that you are a doctor, they always look at you with great suspicion because of the media. And with the advent of Consumer Protection Act, especially, which came in 2019 and 20, the medical practice has become a professional service. Doctors' advice is a commodity now, and patients have become consumers. So in spite of our best efforts, we all are very well trained ophthalmologists, and we know how to do a textbook kind of treatment. But even if we do our best scientifically, we take the right decisions for a patient, the patients can still have complications. It is said that a doctor who doesn't operate will be the one who will not get any complications in his life, right? So this is the need of professional indemnity, because it is important for all of us as doctors to secure ourselves with a indemnity cover in the advent of such a legal act by our patient. And the new CPA Act has come into force since July of 2020, and this is something which is unbelievable, because now even at district level, the patient can sue us up to 1 crore of sum or even more, and they can sue us at a court which is anywhere in the country. So even if you are sitting and practicing in Mumbai, and if the patient belongs to Bareilly, the patient can even sue you in Bareilly, and you may have to actually have repeated travels to Bareilly to have this issue sorted. So it is very important to understand this, and in current times the doctors have to run helter-skelter to attend these hearings, and takes a huge toll both mentally and financially, as we all know. So this is like an unfortunate vicious cycle in which this poor mental health, because of this sudden legal battle, that also means that you're not able to do your practice well. It hampers your monetary incomes as well. And this worry about money makes the mental health go even worse. So it's like a vicious cycle that we have a cascading effect. So the purpose of professional indemnity insurance is to safeguard us from professional risks such as legal defense cost, which can be extremely high, exuberant. Nowadays, there are advocates who, in high courts, for example, even to argue for 5 minutes, may charge you for up to 2 to 3 lakh rupees. Claims for compensations, which are going absolutely bizarre, because you must have heard very, very recently that there was a case against radiologist where there was an anomaly scan which could not detect anomaly, and the baby was born with anomalies, and actually the compensation was given in crores of rupees. If there is any injury or there is a damage borne by even the third party, or there is a breach of confidentiality amongst the other reasons. When the patient's expectations of the compensation are significant because of the new CPA Act, and the cost associated with litigation is so high, as we discussed, the indemnity insurance protects your finances as doctors and also your mental health. So by investing in this policy, you can ensure that finances are protected, you carry on your business smoothly as usual without suffering from cash flow constraints. And therefore it is mandatory. Okay, so it is mandatory. It is not an option now. It is mandatory for all the members to take professional indemnity scheme. So what is the difference between the individual professional indemnity versus a group indemnity insurance? So all the facilities which are given to the individual and the group remain the same. However, of course, there is going to be a big difference in terms of the premium that you pay. And in some instances, while going for the group indemnity insurance, you can get some extra perks, such as inclusion of, especially in ophthalmology, refractive surgery, the staff can be covered, your hospital can be covered, and also you can have criminal cases which can also be covered, which is never covered in individual professional indemnity. So basically, as we have seen, we have to reduce our indemnity fees and also include the criminal cases. Therefore, it is very important that we need to have a group indemnity scheme. And therefore, in 2020, the Maharashtra Ophthalmological Society, which as we all know is our largest state society of India, has taken this special initiative for our members in the form of MOS PGIO, which is Maharashtra Ophthalmological Society Professional Group Indemnity for Ophthalmologist. So this formation was done as a brainchild of Professor Sunaina Malik, who was the president that time, and Dr. A. Deshpande, who is also the chairman of the legal cell AIOS, MOS, as well as chairman of this new committee. I am the secretary for this committee for 3 years, and the current president, secretary, and the treasurers of that year is also part of the committee members. So what are the benefits that this group indemnity scheme is bringing to our members? Is that there is a marked decrease in the rates. For example, for 1 crore cover, you typically have a premium which goes to 25,000 to 32,000 rupees per year for us. And now that has been reduced to almost 7,200 only by the MOS PGIO, which is more than 75% discount on every year of your premiums. All possible and industry's best coverage. So basically every single thing that you can imagine is covered in this. This is also something that is known to have, I think, big benefit to us is that we have Dr. A. Deshpande as the sound medical legal help. So he's the one who receives this notices and gives you opinion, what exactly is to be done next. And the company which we have involved is one of the market leaders, which is ICACI. Therefore, it is a single office scenario. It is a single window scenario where all your claims, your settlements, your queries are addressed by one single person. So coverage is also there for your staff, and refractive surgery is also done in the same premium. The defense cost of the lawyer will be borne by insurance company itself, and you may have also a choice to represent by your own choice of lawyer. However, the fees which will be given to your lawyer will be capped because of the they have a capping system in this as well. All these compensations will be given by cashless manner, so you don't have to pay it and then try and get it reimbursed. And even the multiple claim amounts can be paid up to the same assured within that policy time. So in our setup, we have up to 4 such events can be covered in 1 year, which is, I think, very high. And even the out-of-court settlements are also covered in the MOS PGIO, which is hardly done in the individual schemes. So even if you have a patient who sues you in CPA court or even in criminal court, and if the patient says that, okay, I mean, I'm ready to do out-of-court settlement, but you pay me 3 lakh, 5 lakh rupees as compensation. So that can also be covered in cashless manner by the MOS PGIO group insurance scheme as well. There is a panel of senior doctors as second level consultancy, and they are also going to be helpful in helping you to draft the notices and also in MedicoLegal approach. Cases such as breach of confidentiality and loss of documentation, I think we have just seen that documentation is very important, but even there is a loss of documentation that can also be covered in this policy. But of course, it is always better to have your documentation in place because that goes in your favor in large manner. Cases where there are defamations involved, there is a possibility of dishonesty from the professional. These things are also covered in the MOS PGIO. Importantly, there is no legal fees that our committee charges. And we also do cover COVID-19 related issues in this MOS PGIO. And most importantly, criminal cases which are never taken care of are also taken care in MOS PGI as well. So the premiums, as you can see, are very, very low. For 25 lakhs rupees of coverage, you just require 1850, which is 1,850. And I think now it is important that all of us are actually covered for at least 1 crore of indemnity insurance. So that premium is only 7,210, which is extremely low. So this is important for you to know that this has to be renewed every year. It is not a one-time payment. And as Dr. Marathe sir has said, it is important that you renew it before date. Because even if there's a lapse of days and if you have an event during that time, that will not be covered by this policies. So what is the procedure to get such a indemnity insurance? Of course, this is open to currently to only MOS members. So, but we also welcome AIS members who would like to take it by becoming MOS members with our honorary secretary, Dr. Rajesh ji. You can send your forms and we can include you in MOS PGIO, which by the way is the first such group insurance scheme all over India right now. This was inspired by the Gynecological Society's group insurance, but I think the current rates that we are offering are actually more competitive than even what the Gynecological Society is taking. So this can be done even on digital platform. You can send this to Dr. Deshpande sir, to Dr. Sunena Malik, or to me as Secretary MOS PGI, or you can send it to even Dr. Rajesh as the Secretary of MOS currently. So basically, once all the formalities are done, ICSA Lombard will give you the details of the policy. So what if you have a previous policy which is still running? Even if you have a previous policy which is still running, you can still take advantage of this policy. You may have the option of renewing even the previous policy for the time being, because at least for 2 years, sometimes the policies don't cover the previous cases in some formats. In our settings, we are covering right from the day that you deposit the money. Okay, but it is important that the cases are done only after that. So if you actually become a member in 2022 and if you have a case in 2021, that may not be covered in this policy because of this. But this group policy will definitely protect you in a very big way. So what are the steps to be taken if you get a notice, as I think sir has already told. So once you have taken the policy and if you tend to take a notice, it is very, very important it is essential actually that you involve MOS PGIO committee, and also like for example, if you have your own individual policy, you have to inform your company, insurance company immediately, and you have to make them a party in your case. Because if you don't make them a party in your case right from the beginning, then they are actually not liable to pay a single rupee to you. And there have been cases, multiple cases such as that, where even the Supreme Court and the High Court has gone in favor of insurance companies who actually have failed to compensate the doctors for this. So it is important that you forward them the notice, keep them in the loop at every point line, and you should not lose contact with them, because every update is actually required if you want to take insurance scheme from them. So friends, so as I've said, this was a brief about why you need it and what are the benefits of MOS PGIO. We actually would like, if there are any AS members also, for you to become MOS members and take advantage of this scheme as well. And if there are any questions, we will be very happy. Yeah. So basically, 1:1 ratio means that at one point, only one case can be taken in. But in 1 year, we have 4 cases which can be done through this. Yeah. Yeah. Yes, AS members from other states can also take advantage of this scheme if you become MOS members.
But
you will have to become members of the
yeah.
Maharashtra Ophthalmological Society.
Yeah,
You can
doctor-
run two policies simultaneously if you want. There are some members from our state who has done that as well. Like AMC also gives policies. So if you want to keep both going, it's fine.
Yeah, sir. Yeah. One thing I just want to ask: if any IIS member wants to become member of this PGIO committee,
Not a committee.
no,
Yeah.
PGI scheme.
Take help. Yeah.
They need to practice only in Maharashtra or pan India. They can practice anywhere.
No, they can practice anywhere, but in like because ICICI will do cover them for all over India. Okay, but so their documentation has to be very, very clear about. I mean, I think all over India, wherever they are practicing, it should
Yeah.
be fine.
One more thing. 1:1. He asked. 1:1 means if your policy is of 1 crore and if you are sued for 1 crore, they will give the whole 1 crore. They will do it for 4 times, but the capping will be in the first case you lose and you are awarded 25 lakhs. Patient has sued you for 1 crore, you are awarded 25 lakhs, he will give 25 lakhs. But again, the second case arises in the same year, you will get 1:1 cover. So 1:1 is the highest and most expensive cover you can get. 1:2 is diluted. So if you get 2 cases, their liability of insurance company will be 50 lakhs only. If you get 1:3, it will be 33 lakhs. So in this scheme, it is 1:4. That means 25 lakhs is the capping if 4 cases arise, and 5th cases they have no liability, the insurance company.
Right. Yes. So we do provide with some legal help also because. Yes. So basically, when we say about legal help is they will be giving you some help and guidelines. Okay, so the lawyers will be appointed by you or with the help of the insurance company. But Dr. A. Deshpande, who is the chairman of our MOS PGIO, as well as the legal team of MOS and AIS also, he will help you to basically go through your papers,
Formulate the
help
strategy.
you
He will formulate the strategy.
even guide your lawyer.
Documentation.
So basically, I think as Dr. Marathe sir has said, it is important that I think your lawyer doesn't understand the medical aspects. So when you have a medico-legal expert who is helping the lawyer, will always be beneficial to you. By the company. So basically, if you take the lawyer from them, right? So basically, then of course they have a panel of lawyers, and there is no issues. Yes. ICICI has everywhere in India. That's not a problem. So basically, I mean, what I mean to say is that, for example, if you go for a senior counsel and they charge you 5 lakh rupees for argument, of course the company may not pay it, but with the company you can discuss and you can formulate what they would like to pay you.
Yes, sir. Please.
Yes. Right. So actually, like in our medical insurance, in fact, both the companies, you should actually approach only one company. From
You have to inform both the companies. It should be on the record of both the companies that you have been sued, and then you can decide from which company you need to take.
But you can take protection from only one company. So for example, in like cataract surgery, when a patient comes to you, right? So if you have 2 insurances, he says, I have a 24,000 capping for cataract in one and the 24,000 capping in the other. Can you do cashless in both? But you can't, because you have to actually process the document from only one company. But you should inform to both the companies, but keep only one company in the loop. Yeah.
Sir.
In one hospital, 2-3 doctors are working. So you should take hospital's insurance or all 3 doctors individual?
Both has to be taken, sir. If
Yes.
they are MBBS doctor, both doctor individual as well as hospital. Hospital as a company or as a corporate entity or as a proprietorship, they should have their own insurance, and the hospital doctor may be visiting 4-5 hospitals, so he has to have his own insurance.
Patient can sue both hospital as well as patient.
Absolutely. So there are instances.
Then if he is insured, then insurance will take cover, but you have got vicarious liability. So for vicarious liability, if you are a hospital owner, you have to take hospital insurance.
So that any doctor comes there, he can operate there.
Yes, but you have to inform the insurance company, so and so is now started visiting your hospital as a consultant, honorary consultant.
So
It
basically
should be on the
nowadays there are
record.
a lot of setups which give access to the other doctors, even for LASIK procedures, for example. So if there is any complication, there is a chance that the patient can sue both the operating doctor and also the hospital where it was operated. So I think as Dr. Viral said, it is important for hospital to also have it, and doctors who go freelancing. So I think it is important for them to have it, because then they are covered everywhere that they go to. Yeah.
Hospital insurance is very important because your staff is also liable. Your sister, your attendant, your OT attendants, they are all
So in this scheme, all the staff is also covered. So that is one of the benefits, and refractive surgery is also covered.
3 years from the date of incidence. Any case, 3 years from the date of
From the
incidence.
patient's point of
Sometimes
view, yeah.
court gives them the extension.
Some leeway is
Sometimes
there,
court gives them the
except but
extension.
that is the exception, not the rule.
No,
So,
actually,
only after 18 years of age we are doing LASIK. We are not doing below 18.
so I
But
think
if
as
if
said
it's a
correctly,
pediatric, if it is a
although-
pediatric case, yeah.
Yeah, as said correctly, it is 3 years. But what happens sometime is that it can be extended. For example, if the patient is in your follow-up, for example, you are done surgery, LASIK procedure 3 years ago, and you see the patient after 2 years, and patient develops ectasia, you have seen it, and then he's under your follow-up. So the patient can sue you even later on, because he can still say that I was under care that time. So your documentation should be correct. Yeah.
For pediatric patient, it is after he achieves major age 18 years, 3 years from that. So if you have operated 12-year-old boy for cataract, he can sue it up to the age of 21 years, till he achieves 21 years, because consent was taken from parents. When he becomes an adult, after 3 years, till that time you have to maintain its record for pediatric cases.
Yes.
So I want to ask you a question, not regarding this, it's regarding MMC rules. In continuity of care, a scenario where suppose one surgeon has operated a cataract, maybe that patient has shown you first, you have detected the cataract, he doesn't come to you, he has gone to another surgeon, got the cataract operated, there is some problem. Or there is no problem, just that the surgeon is so busy that he is not able to see him post-op, because you have high-class surgeons who think they only operate and they don't care about the patient post-op. So he says, "अरे उधर तो बहुत गर्दी है, तो मैं नंबर के लिए आपके पास आया." So in this scenario, are you liable to see this patient? As
See, I think as second doctor, you can give the spectacle prescription to the patient, but suppose there is some complication and which was not taken care by the person who has operated, that is problematic.
The question is asking,
question
I am answering. You have the right to refuse patient. You have the right to refuse patient.
No,
if you don't want to see, you have the right, just to say politely,
No, in that, as per MMC guideline, it is mentioned there is a continuity of care, and if that patient comes to you, in mandatory, it is required that the operating surgeon or whoever has seen him before has to write a letter of referral saying that, otherwise it amounts to abandonment of the patient.
I think it is like chartered accountants, we need NOC.
No.
In medical profession, there is nothing like NOC. Patient
no surgeon is going to write, I am not, I am very busy to see the patient. He's not going to, his hospital is there to take care. He will have some assistants to take
According
care.
to me, if the patient comes to any doctor anywhere in the world, you have to see the patient. You cannot refuse.
But if it is a post-operative
Whatever
patient,
it may be. Suppose even post-operative it is more
You have right
important.
to
It is more important because suppose there is some complication.
He's
it is an
operated
emergency.
somewhere. He has operated somewhere
Still,
else, but
suppose
he's
he's
come for
not
routine care.
so
Suppose
there is a liability of the operating surgeon to see that patient for some period of time. If suppose there is a late end of which can happen in 1 year, if I see him and something happens, he will hold me responsible. So
No,
what
no,
is
no,
the
no.
responsibility of the
no,
operating
say,
surgeon?
whenever
You
you are
will-
checking, it is your diagnosis and that has to be that way comparatively perfect. That does not mean that you are taken liable for that. You can tell the diagnosis. You can tell the patient that this particular care has to be taken henceforth. But according to me, yes, you have to see any patient, whosoever is operating, you cannot refuse the patient. At the most, what you can say, there is some complication. I am referring you to the doctor who has operated.
Yes.
That's what you can do. But you don't refuse the patient. That's what I feel.
Seen it late post-op and some complication occurs after 1 year, you are not liable. You are only given medical management. You are not given surgical management. Yes. No, you are not liable, but your documents, whatever you have written, will be produced as evidence in the court, and you may be called as a witness or expert. Ki, what were your findings when that patient came to you?
Because now I practice in the periphery.
Yes.
So I see a lot of specialist cases as a referral.
Okay.
Because the patient cannot travel, they come to the setup, we
Yes.
see them as a secondary
Yes. Yes.
specialist. So in that case, we would just, like you pointed out, are we responsible as well? For
No,
the
you are
diagnosis?
not. But then politely you can say that I feel something else which I cannot detect, or I cannot treat, or I cannot take this treatment forward. I advise you to go there. Suppose it is
Rather
straight.
than mentioning
Yeah.
in the
Suppose it
paper
is
that
straightforward follow-up.
No, we have
You
to
can
mention
do
on
it.
paper.
No, do we have to mention because we might risk the fellow surgeon as well?
No, no,
Other-
no. You
there
just write down, refer to the operating surgeon or to the
We do not mention
for
what
You
further
need not
matter.
mention. There is something what you have to show your original surgeon. Another thing is loose comments is the important thing in medical legal aspects. Don't do loose comment. Whatever you feel like, tell politely that that doctor, that surgeon at that point of time must have thought about your diagnosis like this. Today this is the situation, but don't do any loose comment. Okay.
So thank you everyone. Thank you to my co-instructors, Dr. Vardhman, Dr. Rajesh Joshi sir, Marathe sir, Dr. Raju, and see you all in the next IOC, hopefully at Kochi. So thank you. I think we are already infringing on the next IC's time.
I think it is a wonderful IC designed by Dr. Viral Shah, our chief instructor. We must congratulate him and thank you so much for giving us the opportunity.
Thank you, sir. Thank you. Thank you so much, sir.